ASH tool for planning post-remission treatment for patients with acute myeloid leukemia. This was work produced by ASH in collaboration with the Mayo Clinic Shared Decision Making National Resource Center. This is a conversation aid to help older patients and their clinicians discuss post-remission treatment. It's not a script. It's not intended to help discuss anything other than concerns your patient may have related to this treatment and find the approach that's best for them. So after reviewing who is eligible, let's begin. First thing to point out is that this discussion is positioned towards this idea of having achieved remission. How do we stay in remission? How do we prevent recurrence? And this tool is to help the conversation and introduce two treatment approaches, a chemotherapy-based approach and a stem cell transplant one, and compare how they might affect the patient's life. There are multiple places to start the conversation, and these are represented in the tabs at the top. One could start the conversation by presenting the options, working through the timeline and planning required to implement them, the outcomes expected, and then some reflections about what to keep in mind when going forward. In this first tab, and so by the way, there is no particular order in which this should be covered, and not all aspects need to be covered. This is more a way of structuring the conversation and guiding it, but it doesn't, again, behave like a script. So in this particular tab, we present the two options. One option is to continue with more chemotherapy after achieving remission to lower the chances that the leukemia will recur, or to proceed with stem cell transplantation. The second tab allows us to explore in more depth what this involves in relation to the timeline and the planning required to implement these tools. Here it shows that after the initial treatment of leukemia, this is the moment in which this conversation is happening, there might be opportunities to proceed with more chemotherapy, which will include multiple cycles over time. This I button can be pressed to remind us that the process of initiating and scheduling chemotherapy may involve figuring out where the treatment will take place, and this is quite flexible compared to stem cell transplantation. Some of the adverse consequences that we can review with our patients, including fatigue, some of the complications associated with those side effects, and how the courses of chemotherapy can disrupt daily routines. For the other approach, which is to give chemotherapy and prepare for stem cell and conduct a stem cell transplant, we also provide an additional point here, which is that in order to set that up, there's quite a bit of planning involved here, and this is not an exhaustive list, but a guide to that discussion of that planning, including, selecting a transplant center and find a donor, but also recognizing that completing the evaluation for medical, psychological, and social suitability may involve travel and time, may involve organizing resources, including ensuring insurance support and securing caregivers who will join the patient in this journey. And that all that preparation will require manage carefully the timing for all these activities that may then arrive at the point of transplantation and then recovery. The I button here helps understand that this process of transplantation may require up to monthly hospitalization, staying near the hospital for an additional 2 months, including chemotherapy and infusing the new stem cells. And then as the patient essentially goes home, recognizing that the patient will have to rely on caregivers for ongoing support, that this will reduce the energy and vitality of the patient for a while, that they may be important to limit contact and other restrictions of daily living, and that there may be some side effects and complications from the transplantation to keep in mind. So that this page is intended to set the stage for the demands that these two approaches will have on the patients and their caregivers, and the timing and the planning that will require to undergo stem cell transplantation. The Outcomes tab helps share with patients what to expect with and without treatment. We can click on without treatment and understand that even after achieving remission, if no additional therapy is offered, out of 10 people like the patient, this is what we would expect at 5-year time, that 8 patients would have died in that period of time, and 2 may still be alive at the end of 5 years. Of course, it's always helpful to indicate that these are estimates only, and that the patient's actual risk may be lower or higher than was presented here. And then what will happen with treatment can be explored in this graph, both for the chemotherapy option as well as for the stem cell transplant option. Once again, at time 0, everybody has achieved remission, and we can see that with chemotherapy at the end of 5 years, 3 patients now survive and 7 have passed away. Of course, it's always helpful to indicate to the patient that we have no way of knowing if the patient is one of these green ones or one of these purple ones. With stem cell transplantation, you can see the rates in the bottom. For some patients, clinicians may want to suggest a higher or lower benefit, and this plus or minus signs can change the prognosis that is shown here. Similarly, we may want to have a discussion that is more short-term, and by clicking on the 1-year time frame, we can see the effect of the first year of therapy around stem cells in relation to early mortality, and what will happen for comparison if we pursue the chemotherapy-only route. Finally, if we want to discuss a particular source of suffering in patients that undergo stem cell transplant, there is the graft versus host disease tab that allows us to identify that this could happen shortly after transplantation, but also can affect the long-term quality of life, as in these 2 points, and survival, as in this one, of patients undergoing transplantation over the next 5 years. It's always helpful, once again, to remind the patient that we have no way of knowing which of these dots represents this particular patient. After reviewing the purpose of the treatment to prevent recurrence, the timeline and planning of the treatment, and the outcomes that can be obtained from pursuing these courses of action, it may follow, although not necessarily, but it may follow that there's an opportunity to stop and reflect. Perhaps it's important to think about the issues discussed with others who may not be present in the encounter in which this tool is being reviewed. And the topics of discussion can be, the risk and benefits of the different alternatives, their feasibility given the situation of the patient and the disruption in life that these options will consider, the effect on family and other important people in their lives, and to discuss what it means at the current stage of living of the patient and the meaning in their life story of pursuing this additional therapy. So these are opportunities to have in-depth discussion about what it means for this patient to pursue this course of action. The tool finishes by offering an opportunity to bring closure and completion to this discovery of what to do and how to do it and why to pursue it, by basically stating, are we interested in taking some time to discuss the options? Are we interested in perhaps planning or more chemotherapy now and forego the idea of stem cell transplantation? Perhaps the next step is to discuss with clinicians from stem cell transplant centers, which basically now requires us to think about which centers to consider and how to be referred to the relevant one, and also how to begin to identify potential donors and potential caregivers that may join us in this journey. And then finally, the same set of questions if the patient is readier to proceed with making plans for stem cell transplantation. Once again, this whole process is not necessarily one to be discussed linearly. Patients and clinicians in the consultation may want to go back and revisit other tabs as to just clarify and further the conversation. And the process of this is not to identify or convince the patient of a particular course of action, but to discover with them how might we address the threat of recurrence, and how might we, in deciding how to pursue it, address that threat, identify the reasons why pursue them, and take on the practical steps to achieve desirable outcomes.